This is Emily Peters recording respiratory and blood disorders and one cardiac disorder for Care of the Growing Family. All right, let's get started. All right, so hemophilia is one form of blood disorder that is hereditary. It is X-linked, meaning X-linked meaning that it is recessive, and you have to get the gene from both your mom and the dad. There are several different forms of hemophilia. It is a deficiency in clotting factor that affects the coagulation of blood. There are three main types: hemophilia A, hemophilia B, and von Willebrand's disease. Hemophilia A is the most common form. This is deficient in factor 8. Hemophilia B is deficient in factor 9. And then von Willebrand's disease is deficient in factor 8 and this VWF disease. Von Willebrand is named after the doctor that had this disorder. Christmas disease, or hemophilia B, is named after, I believe, the little boy that had it first. And then hemophilia A, well, just I don't know why they named it that. Let's see. Hemophilia A affects boys. 85% of the cases are hemophilia A. Girls can also get this, but they would need to have 2 of the X links. Hemophilia B is can affect girls as well. So basically, with the hemophilia, the patient is deficient in one or couple of hemophilia factors. With hemophilia A, they're deficient in factor 8. And the more deficient they are in that factor, the more severe the disease. Anti-hemophilia factors are produced by the liver and is necessary for formation of thromboblastin in phase 1 of blood coagulation. With hemophilia, the bleeding can occur almost anywhere, but it is most commonly occurring in the joints and muscles, because those are areas that are used the most. Like your knees, they take a lot of wear and tear throughout the day, so that's one area that you see an issue in. Your arms, your hands, your fingers, things like this. What you end up seeing is swelling, warmth, redness, pain, loss of movement, especially with reoccurrent with a reoccurrent damage or inflammation to the joints. One area that we don't always see problem, but they can get bleeding is intracranially. And because we don't see the issues until they've had a lot of blood pooling, that can cause major impairment to the patient. Let's see. This can lead to crippling deformities because it can cause damage to the joints. Especially the more times that they have damage or inflammation to that joint. Okay. So bleeding tendencies can be very mild to severe. Part of that also depends on the inflammation or the blow or injury to the extremity. And also depends on how deficient they are in the factor as well. Typically you may not see the first symptoms until the kid's 6 months of age, and what's happening then, that baby's starting to get more mobile. They're starting to crawl, they're starting to stand, they're starting to use joints, extremities, and things. One of the most common things, like I mentioned, is in the joints, and into those spaces, knees, ankles, elbows, warmth, pain, bruising, decreased movement, things like that is what we see, swelling. So what do we do for these kids? Well, we need to replace the missing clotting factors with plasma or genetically engineered recumbent. So for those of you that donate plasma, this is one of the types of patients you are helping. We also have desmopressin. It can be given IV, nasally. I believe they have now an oral form as well. Desmopressin increases the factor that they're missing by 2 to 4 times. It does have some major side effects and things you have to watch for as well. We can also do transfusions for these patients. Transfusions of blood, plasma, and the engineered recumbents. Exercise and physical therapy is very important because it can strengthen those joints, and that way, therefore, it can decrease those spontaneous bleeding issues due to everyday movements. And it also helps for decreasing the long-term issues that could occur with recurrent injuries. Okay, so here's interventions for hemophilia. So we need to prevent the bleeding. So safe environment for infants and toddlers as they're growing. So no loose cords, rugs, things that they can trip on and cause injuries. Soften corners so that if they bump into them, it doesn't cause severe bleeding. School age, and as they're learning to ride bikes, tricycles, things like that, they should be wearing those protective gear. Typically, hemophiliacs shouldn't do contact sports, even though there are some that do, but they are followed very closely. The school nurse and teachers should be very aware of what's going on with the child so that they can intervene faster. We do not give NSAIDs, for example, ibuprofen, to those with hemophilia. Some other NSAIDs that we shouldn't give: aspirin, Advils, ibuprofen, Midol, Motrin, Bufferin, Bayer, Alka-Seltzer, Excedrin. Pepto-Bismol has blood thinning components in it as well. So those are some things to think about as so basically pain relief medications for these kids is limited to Tylenol. Recognizing and controlling bleeding early. The earlier we intervene, the better and less likely for long-term damage to the joints. Most kids recognize it because they're used to it. So then we need to get those factor replacements, such as the desmopressin delivered quickly. Another thing we'll do in cases of the inflammation and swelling is RICE, rest, ice, compression, and elevate. And then after the swelling and everything goes down, we need to make sure they're doing passive range of motion so that they can keep moving those joints. Because if not, they're going to develop those contractures that will then cause them to be having immobility issues. Another thing that I like to discuss, and hopefully we've had better education across the nation about this, but I think we're still having some miscommunication, is because we are giving these patients a lot of donated blood and plasma. There's still that question about HIV transfer with transfusions. And remember, that is very rare to happen anymore. The risk since 1985 has been almost eliminated. So that is one thing that once again confirm with the families, is that these kids should not be able to get some sort of blood transferred disease such as hemophilia through the transfusions they're getting, because we have done such stringent screening of patients before they donate and testing of donated products. Prognosis for hemophilia is really good. It used to be that they died very early, but because we have done so much research and are able to catch things sooner, and we are able to give them treatments faster, patients with very low to moderate hemophilias can live very normal lives and live for a long time. We're working on gene therapy to also target cells and to help promote the manufacturing of deficient cells. So maybe we'll have even longer living and success with these as we grow. All right, respiratory disorders. This should be a lot of review at first, and then we will go on to some specific ones you may not have heard of before. So guidelines of assessment for respiratory system. It is exact same things that you would do in the adult, except for you have to do some different unique ways and explaining things to make it less traumatic for those babies and toddlers. So atraumatic. Things to look for that could be a sign of a disorder. Fevers, anorexia, so not eating, vomiting, diarrhea, abdominal pain, nasal blockages and discharges, cough, respiratory sounds such as hoarseness, grunting, stridor, wheezing, crackles, diminished sounds when we listen to them, harsh sounding, sore throats, headaches, stiffness to the back, a petechial rash, which would actually be like meningitis, which can develop from respiratory problems. Okay, and these are just a few of those respiratory assessments. I'm sure there's more I did not mention that you guys should already know. So some treatments, nursing care management, what is it? It's non-pharmacological. Ease their respiratory efforts. Get them rest, comfort, fluids, hydration, preventing the spread of infection, cleaning, hand washing, teaching them to cough into their shoulders or into, not their hands. Reducing their fever, getting them eating. So some things that we can do to ease it. Warm and cool mist, humidifiers. But remember, those can cause burns, so make sure it's out of the way. Bed rest. Comfort. You can do saline nose drops or nasal aspirators, those bulb syringes, neti pots if the child's old enough, throat gargles and lozenges, and if the kid is old enough to swallow and suck on a hard thing. So that might be more school age. Cold and heat packs, hand hygiene, no sharing of cups, covering a cough, like I mentioned earlier, Tylenol, children's ibuprofen over the age of 6 months, cooler liquids, hydration, hydration, hydration. So water and oral rehydration therapies like Pedialyte. No sugary drinks. Family support. Okay. Keep that child comfortable. We do not give over-the-counter meds to kids under the age of 6 without the direction of a licensed independent practitioner, because there is easy to overdose. So guaifenesin or Robitussin, things like that we do not give. Mucomist, Mucinex, things like that, without talking to your doctor. Upper respiratory infections, I'm sure you've all had some of these. So the common cold, nasopharyngitis, it's typically viral, that stuffy nose. It sounds like I have it right now, but mine's actually allergies. Maybe have a fever. What do we do to help them? Elevate the head of bed, suction, increase fluids that cool mist humidifiers. If antipyretics for their fever, rest, and that's all you can do. RSV, rhinovirus. Okay. Pharyngitis. So that's your sore throat. These can be viral or bacterial. Diagnosis is a nasal swab and an oral swab. That throat swab is the most important to determine if it's viral or bacterial. It's caused typically by group A beta hemolytic strep, and if that's the cause, then it's bacterial. So cough suppressants. So make sure with this that if you have a patient that has a sore throat, that you not only do the quick strep, but you also do the strep culture as well. The quick strep test is not 100% accurate, like it's 50% accurate. And if we do not diagnose this quick enough, it can develop into rheumatic fever, and we'll talk about rheumatic fever next. If it comes back positive for group A beta hemolytic strep meaning it's no longer viral, it is bacterial, then we need to make sure we get these kids on their antibiotics quickly. And they need to be on their antibiotics for somewhere between 7 and 10 days, depending on what the doctor orders. Penicillin. After they've been on that antibiotic for 24 hours, they can go back to school. You also should sterilize or get them a new toothbrush. Otherwise, they're just going to keep infecting themselves. Some things that they can also do is warm saline gargles and cough suppressants and lots of fluids. Okay. If group pharyngitis or strep throat isn't well treated, it can turn into rheumatic fever. This is the nice tonsillitis pharyngitis right there, nice inflamed tonsils, and then you can see the white exudate, that is the pharyngitis. That could very well be the bacterial form. All right, so rheumatic fever. So this is why I get so crazy about making sure we do both tests with these kids. Rheumatic fever can be very detrimental to our patients. This is an inflammatory disease that starts out with strep throat, that then ends up affecting the heart, the joint, and the central nervous system. And it can also affect their subcutaneous tissues. One of the major parts of the heart that is damaged is the mitral valve. And it can scar and then cause that mitral valve not to work anymore. Okay. This is due to not well-treated group a strep, and within 2 to 3 weeks, they can develop rheumatic fever. We can prevent this from occurring by getting those antibiotics on those kids and making sure the families follow through and take those antibiotics like they're supposed to. So diagnosis of group or rheumatic fever, you're going to have the presence of 2 major criteria and one major and 2 minor of the Jones criteria. The next slide has those Jones criteria. Okay, so Jones criteria. Carditis, which is tachycardia, a murmur, friction rub, EKGs, changes, okay, polyarthritis, swollen, hot, red, painful joints, erythema margitum, that's the picture that I'm trying to show here. So it's on the trunk and the extremities, it kind of has a clear center and this dark border. So it's a rash that they will have. Subcutaneous nodules, you can kind of see on that middle picture, that are over bony prominences, and they're non-tender swelling. They will resolve as the rheumatic fever is treated. And chorea, these are those sudden, irregular movements of the extremity. You might see facial grimaces. You may have speech disturbances. They can have weak muscle tone, things like that. Minor criteria, I apologize that these were cut off. They should be on your slides. Arthralgia, fever, elevated antitrypsin O titers. So elevated antitrypsin O titers. Elevated electrolyte stimulating rate, C-reactive protein, which tells you about inflammation, and ECG changes. They need to have either 2 major or 1 major and 2 minor, or a combination of all of them, along with having strep throat previously. These effects can be long-term for these patients. All right, management of rheumatic fever. Penicillin, NSAIDs, corticosteroids to help with the inflammatory process and decrease fever and discomfort. Bed rest. Once they have been, their initial penicillin treatment is done, they will then go on to prophylactic treatments to prevent reoccurrences, because once you have it, you're at higher risk for getting it again and having more damage to your body. They will get either monthly penicillin G IM injections, okay, or they will get oral doses of penicillin or a sulfa if they're allergic, and they have to take that so many times a week and it's like a very low dose for anywhere from 5 years or longer, because we do not want long-term damage to that heart. If they're not going to take their oral dosages, then they're going to get the IM injections. Compliance is very important because we do not want them to have long-term damage to their heart. This is just showing doing a throat culture. Make sure whenever you do throat cultures to do it right the first time, because they're not comfortable and we don't want to keep repeating these. All right, tonsillitis. I'm sure some of you have had tonsillitis. Tonsillitis is often hand in hand with pharyngitis, like that picture I showed you also earlier. The tonsils are actually really important. They used to believe they did nothing, so we took them out a lot faster. The tonsils filter and protect the respiratory tract and from invasion of pathogens and help with antibody formation. So that's why we try not to take them out as quickly as we used to. Okay? Tonsillitis is often hand in hand with viral or bacterial pharyngitis. Treatment of severe recurrent cases of tonsillitis would then be that tonsil and adenoidectomy. Okay? Every resource I've read says a different number of times that you have it before they take them out. I think each doctor has their preference. Okay, I'm not going to test you on what point you would take them out. Okay, so what do we do? With tonsils and adenoidectomy, post-op care is important. Okay, first off, when they're coming out of the OR and they are still under anesthesia, they are going to be on their stomach or their side. They may even have a like a pillow underneath of them to elevate or to make their head a little bit lower from the rest of their body. Okay, we want to facilitate drainage. Once they're fully awake, we do the head of the bed up and or on the side. We don't want them to cough or blow their nose because that can actually cause hemorrhage. Signs of hemorrhage would be bright red drainage, excessive swallowing or clearing of their throat. You may see increased pulse or pallor. Their mucus is sometimes blood tinged. But that would be normal. If it's a lot of blood in that mucus, then we would be concerned. Okay. We don't want a lot of blood with emesis. A little bit is okay. While they are dealing with post-op and wake, we'll do PO liquids, PO Tylenol, as long as it's not colored. We also may do suppository if they're not wanting to swallow. Ice collars while the baby or toddler's awake, or the 2 or 5-year-old or 10-year-old is awake, because that'll help with inflammation. Fluids, ice chips or water. No red, brown, or citrus fluids. Actually, milk can coat the throat, so we want to wait for a few days before we introduce ice creams. No reds, oranges, purples, anything that can maybe look like blue in the emesis or look like blood in the emesis. Okay, it's typically an outpatient surgery unless there's complications, and then if the kids are under the age of 2, they may watch them for 24 hours in the hospital. Croups. There's all sorts of different types of croup. This is that hoarseness, barking, cough, stridor. Epiglottitis is a form of croup. Laryngitis, laryngeal tracheal bronchitis, tracheitis. They even say bronchiolitis or RSV is a form of croup. Laryngeal tracheal bronchitis is the most common form. It is a virus. It is inflammation or edema of the mucosal lining of the larynx and trachea, which leads to narrowing of the airway. So some things to think about when you're looking at the airway of a child and why respiratory problems are so much severe in infants and young children compared to an adult is looking at the size of their airway. They say the size of a child's airway is about the size of their pinky. Okay, and if you would compare your pinky to your thumb, let's say, and the thumb would be comparable to the size of an adult's airway, then you could see how any inflammation that the pinky would swell up and close off easier. Another thing that happens in these airways is they get shorter as well. So they swell closed and they get shorter, which makes it harder to breathe. Think about it is if you're drinking through like a shake through a straw, it's very hard to get through, and as you're drinking that shake, what happens is that straw collapses down and it closes off. That's similar to what's going on in that child's airway. So this is a great mnemonic for what croup is like. Slow onset, barky, crowing like cough, Stridor, you see symptoms worse at night, definitely during the fall and winter. They may be hypoxic. They may have a low-grade fever. They have had an upper respiratory infection before they had the croup-like symptoms. They're restless. You may see some substernal or lower rib retractions, and they're breathing really fast. The respiratory distress will get more severe the more the swelling and obstruction occurs. So in that assessment, the hoarseness, those coughs, like in the other thing on that slide before, the respiratory distress stridor cyanosis would be a very severe sign. How do we treat it? Humidified air. All these things, the treatments for the most part, until it becomes bacterial, is going to be over-the-counter things. Humidifiers, oxygen tents. If they're really struggling to breathe, we're going to put them NPO, because if they're eating, that's going to increase their respiratory distress. If they're struggling and need to be hospitalized, we may give nebulized epi. Cool mist humidifiers, water, as long as they're not struggling to breathe. And if we are going to have an obstruction due to it, we're going to see an increased pulse, increased respiratory rate, severity of retractions, flaring of the nares, restlessness, and decreased in their stats. We will sometimes give them dexamethasone or a steroid as well to help treat if it is severe. Most times, croup or laryngeal tracheal bronchitis is treated at home. Another one of my favorite things to do with croupy-like symptoms is to steam that airway open in the bathroom. So turn that shower all the way up to high, the hottest that water can be, and get that bathroom nice and steamy, and have that child sit on the floor on the toilet. And then once they've been in there for several minutes, you'll start noticing that they're breathing a little bit easier, and then take them outside to the cold air. One will cause bronchial dilation, and the other will cause some bronchial constriction, and both of these will help ease their respiratory rate. If it is not super cold outside and you have a deep freezer, open up the lid to the deep freezer and have them lean their head over top of it and even into it a little bit without closing it. Do not put the child in a freezer. That will be enough of a cold air to help ease the symptoms. Spasmodic croup, which is very rare. This sometimes doesn't have any respiratory symptoms before it, and it's typically what I consider a one and done type of thing. So they may have it one time, just have one occurrence of it, and then not have it again, or they may have it again months down the road or in a year or two. This is a very sudden attack of that spasmodic croupy cough. They have no fever, no signs of inflammation before it occurs, and then all of a sudden in the middle of the night they have that barking cough, the hoarseness, restlessness, and increased dyspnea. What do the parents do? They may take them into the steamy bathroom as they're gathering all their stuff to get them to the ER. So they steamed them open in the bathroom, and then they take them outside to their car. And what happens? That cold air causes another shock to the system, and guess what happens? Their breathing starts to ease. The symptoms start to subside in the next couple of hours, and they never see it again. Laryngitis, that is that sore throat, scratchy throat where you're losing your voice, nasal congestion, fever, hoarseness, fluids, humidified air, rhinitis. I have this constantly due to allergies. That's that stuffy, sore nose. What do you do? If it's related to allergies, take your antihistamines and leukotrienes. If it's just seasonal rhinitis, nasal washes can work as well in blowing your nose. Bronchitis, that's the dry, hacky, non-productive cough. Big thing is just treat the symptoms. If it's severe enough, the doctor might order some sort of medication. Pneumonia, I'm not going to go into. You guys should know about pneumonia, but with chronic lung disease, this can be very reoccurrent. Okay. Bronchiolitis, or RSV. This is most often seen in children under the age of 2. It begins in late fall and peaks in the winter. Has a very common season, just like the flu. It is easily spread and very contagious. This is the bronchial mucosa becomes very edematous, filled with this thick mucus and exudates, which then leads to airway obstruction. They end up with hyperinflation of their lungs, atelectasis because air is trapped into the distal portions of the lungs because of obstruction, and then they get overinflation. It kind of reminds me a little bit of like an emphysema-like situation. So the assessment of bronchiolitis, they typically end up with an upper respiratory infection like rhinorrhea or a low-grade fever, maybe a cough or ear or eye infection beforehand. And then we start seeing an increase in the respiratory distress, start having coughing and wheezing, and then their cough gets more intensified. We see the crackles, diminished breath sounds. They become tachypnic, maybe even apneic in severe cases. And may not even hear breath sounds on auscultation. Most forms of RSV can be treated at home, but severe treatments will need to be in the hospital. This can be deadly for some kids. They'll do an x-ray. They're going to see hyperaeration of the lungs and lots of consolidation in there, all that exudate that's built up in the lungs. They'll do that ELISA, enzyme-linked immunosorbent assay. This one will be nasally, and they're looking at those nasal secretions, and they're specifically looking for respiratory syncytial virus. Remember, it's a virus, so antibiotics will not help this child. So treatment would be high humidity, lots of fluids, and rest. Like I said, most cases it's treated at home. You're going to want to make sure your healthy kids stay away from your kid with RSV, especially if they're under the age of 2. In the hospital, we'll do oxygen, IV fluids. They'll probably be NPO. They may do some cool mist humidification. They will give an antiviral like ribavirin, RIBAVIRIN. And that is just to help with the viral infection. It's all mostly supportive care, lots of rest, NG feeds if they're in the hospital, and oxygenation. These kids will be isolated because if they're in the hospital, there's other super sick kids, and it's very contagious. And then if another kid gets it, it could be deadly to them. There is a preventative med for this to help decrease, kind of like the flu vaccine, that we can give to high-risk kids. So preemies or kids with chronic lung disease or kids that are immunosuppressed can get the Synagis shot. The Synagis shot is, it is a monthly IM injection they will get every month for the flu season. I think the copay after insurance is around $100. I think it's $300 to $400 without insurance or something like that. It does not prevent the child from getting RSV per se, just like our flu shot doesn't necessarily prevent us from getting the flu, but it should hopefully help cause the symptoms from being less severe and not as deadly to those high-risk kids. In the hospital, when I've taken care of kids with RSV, they are isolated and they're segregated from the kids that do not have RSV. So the nurse that's taking care of a kid with RSV, the whole next several shifts that she's on, once she's taking care of that kid, she probably will not take care of any other kids. They'll just be isolated to that group, and they usually try to separate them in the hospital. Okay. Epiglottitis. This is a medical emergency. It has a very abrupt onset that is preceded with a sore throat that then rapidly progresses to a severe respiratory distress and laryngeal obstruction. These kids will have severe pain on swallowing. They will sit in a tripod position, sitting upright, leaning forward with their chin thrusted out and their mouth open and their tongue protruding so that they can breathe easier. You may even see tons of drooling while they are trying to breathe, and they can't swallow very well. They will not have a spontaneous cough. They will be very crabby and agitated and air hungry. They're going to be irritable and restless. They're going to breathe very slowly and deeply. They're going to have a thick, muffled voice. In fact, sometimes it sounds like they're just croaking like a frog. You're going to see severe retractions and cyanosis. If one was to look at the epiglottitis or epiglottis of this patient, it is going to be severely cherry red colored. Okay, us as nurses, if we suspect that this patient has epiglottitis, we will not do our airway assessment of their throat. We'll just listen to their lungs, because once that child opens up their throat, sticks out their tongue so we can see down that airway could immediately close off. So this is one of those assessments that we reserve for those physicians that are well trained, because they may have to intubate or even throw a trachea in these kids' airways immediately. Okay, so if you suspect that a kid has epiglottitis and you're in the ER, make sure you always have intubation equipment ready and also trach kit ready in case that intubation doesn't go well. I love this mnemonic because it is literally life or death. That's why we have that airway getting closed off with the airplanes. Okay. Treatment is getting an airway. So intubation, if we can't ease that airway with just regular oxygenation, we're going to start these guys on antibiotics immediately. And hopefully within 24 hours, that edema will improve. And we can prevent this. The HIV vaccination will prevent this from occurring. So we may be seeing this more frequently now that we have a lot of anti-vaxxers in our society. Asthma. I'm going to run through asthma very quickly because you guys have been taught asthma before. So chronic inflammatory disorder of the airway, reoccurring episodes of symptoms that I have listed here. You have limited airflow and obstruction, and you can have spontaneously obstruction in treatment. Okay. This is a great mnemonic on asthma. Hopefully this is all new review to you. Hypersensitivities and triggers like smoking, dust mites, certain medications, exercise, infections. There is a hereditary tendency with asthma. Chronic lung disease kids will develop asthma easy enough. Increase in mucus, shortness of breath, retaining of CO2, retractions. Okay. So you have chronic inflammation of the airways. those airways become very inflamed and edematous, and then they're just going to kind of close down. The more and more the child has asthma episodes, the more damage it is to the airways, and they can have chronic remodeling of their airways. There's several different levels of asthma. Intermittent asthma is probably what I have. I just have an occasional attack here and there. Severe persistent asthma means I'm having several attacks a day, multiple times a week. Before I get to drug therapy, some diagnosis of it. We typically don't diagnose kids until they're 3 to 8 years of age. It's those coughing, wheezing, shortness of breath. We'll do PFTs or pulmonary function tests in kids that are old enough. So PFTs we typically can't do until the child is 5 to 6 years of age, when they can actually follow steps going on. We do a lot of x-rays in these kids because we're trying to rule out all other issues. So some long-term medications, we have preventative medications. We are going to do quick relief medications, rescue inhalers, daily inhalers, corticosteroids, cromulins, sodiums. I'm not going to go through all these meds because you should have had them in Foundations 1. I do have some slides available with you for some of the med review. Okay. Albuterols, bronchodilators, theophylline, leukotriene modifiers are all more medications that they could have. So the peak flow rates meters, the patients will use frequently when they are first diagnosed, and then after that they will use it to check to see how their medications are working for their asthma. So green means on the meter, you can kind of see in the picture, they have a green line, a red line, and yellow lines. The green lines and higher, that means they have good airflow with the peak flow meter. They'll blow into the meter, take a deep breath, blow into it, and there's that little dial that'll go up. They'll do it 3 times, taking like a minute to 2 minutes in between each breath, and they'll take the average score. Green means they're having good control with their medications. Yellow means we just need to make some changes to their medications. Red means it's an emergency. Their medications aren't working. We need to make major changes now. An inhaler right here it's meter dosed for everybody. Remember, you hold it about 2 finger lengths away from your mouth. You're going to take a nice cleansing breath in. Release that breath, then put the inhaler, have that inhaler up, release the medication in the inhaler, take that nice deep breath in, hold it for around 10 seconds, let the breath out, wait about a minute or 2 in between. That is not the most accurate way to give meds. The reservoir you see here is the best. Same kind of concept. Do that cleansing breath, put the spacer in your mouth, release the med into the spacer, take that deep breath in, and then relate the 10 seconds, then take a deep breath out and do it. In infants, we do nebulizers. Here's a kid with a mask with a spacer. Here's a kiddo getting, he must be pretty sick, so he's getting a nebulized medications. We do exercise to make sure that we're doing good lung exercises. We can do chest physiotherapy to get those excretions out, and then we can do hyposensitization tests to their allergies. Status asthmaticus is a medical emergency. This is when we need to get, they have severe chest tightness, rapidly increased shortness of breath, and we need to get them medications immediately. Acute care, IV fluids, replace those fluids, nebulized albuterol, corticosteroids, things like that. when we're taking care of that kid that is having an asthma attack, make sure you're calm, because if you're anxious, that's going to make them more anxious, which is then therefore going to make it harder for them to breathe. Allow them to sit in a comfortable position. Goals of asthma management: avoid exacerbation, so avoid those triggers. So avoiding smoke, pet dander, chemicals. For me, dust mites, so getting rid of carpet, making sure I'm cleaning really well, and putting dust mite covers on your beds and pillows. Babies and young children that have dust mite allergies, and if you have carpet in your home, putting them on a blanket on the floor versus directly on the carpet, because you can't fully get rid of the dust mites in your carpet. Getting rid of window coverings or cleaning them constantly, because the dust mites burrow into fabric. Leather couches, things like that, are better than fabric couches. Avoiding those other allergens, seasonal allergy things, taking your seasonal meds, making sure they have their inhalers that they can relieve their symptoms immediately, using their peak flow meters, and making sure that they know how to take care of and keep their devices clean, and just education. So there's a little, I don't know why cystic fibrosis is on this slide. Ignore that, but this is a nice mnemonic for asthma. All right, cystic fibrosis. This is a great, I think this is our last respiratory topic. Cystic fibrosis is a great mnemonic for this disorder. CF is one of those disorders that can cause a lot of nutritional deficiencies as well. Cystic fibrosis is a autosomal recessive disease, meaning that you need to get it for both parents. These patients have an increased viscosity of mucus, gland secretions that can cause obstructions to their airway, or any vessels that produce mucus, so even in your pancreas. So mucus obstructs the small passages in the pancreas and the bronchioles. In the pancreas, when the ducts obstruct, then they can't secrete pancreatic enzymes that need to go to duodenum for digestion. And that's where we have our impaired nutrition. They'll have satiaria and azoturia, bulky, frothy stools, and foul-smelling stools. So slimy, stinky diapers. So I just kind of went through some of these. Increased viscosity of the mucus. They can have elevation of sweat electrolytes. We'll talk about that here briefly. Abnormalities in their autonomic nervous system, and then they have an increase of sodium and chloride in their saliva and spit. They taste like salt. Super salty. So some things that can affect their exocrine glands become obstructed with this mucus, and then you can have some bronchial issues, so pneumonia and emphysema-like issues, GI blockages, malabsorption issues, and portal hypertension. So they can have a lot of issues with CF. So their pancreatic enzyme deficiency, they can have COPD-like disease, sweat gland dysfunction. They have failure to thrive due to malnutrition, and their increased metabolic rate. They have increased weight loss despite their appetite, because they're not utilizing their nutrition right. And then they have respiratory deterioration, which can lead to respiratory failure. So on these kids for diagnostics, we do sweat tests for them, and this is to see if they have normal sweat electrolytes. For you and I, we should have about less than 40, and these kids, they're going to have greater than 60, and if you kiss them, even though you don't have a lot of sweat on your skin just every day, you're going to taste salt. We're going to do chest x-rays to see what their lungs look like. We're going to do those PFTs to see how their lungs are functioning. We're going to do stool and 24-hour stool samples. 72-hour stool fat samples for them. We're going to do barium enemas to see where the blockages are and hopefully clean them out. And that's about it for electrolytes. Okay. Complications. So I mentioned that they have fatty stools. Well, fatty stools are hard to get out of their digestive tract, so they end up with prolapsed rectums and intestinal obstructions. Pulmonary wise, they get obstructions in their pulmonary tract. They have poor O2 and CO2 exchange, so they become severely hypoxic and hypercapnic and acidotic. They're like those little COPDers. And what do we remember with COPDers? That we have to be very careful with their oxygenation, because if we give them too much oxygen, they're just going to keep retaining it, and then they're going to need more, and it's going to decrease their drive. Okay. Let's see what else. Let's see, their bronchi and bronchioles obstruct with thick mucus, making it very difficult to expectorate. Remember, your lungs are very dark and warm, and then they're having extra moisture in there, and guess what? They get Pseudomonas and MRSA, MRSA, so lots of infections that can occur as well. So management of cystic fibrosis, big ones is to focus on their pulmonary issues. So we want to decrease those pulmonary complications, making sure they have good nutrition. We're going to also make sure that we're doing chest physiotherapy daily. I believe it's twice a day, once in the morning and once at night at least. We're going to make sure that they're taking the bronchodilators right before, and then we do the chest physiotherapy. These pictures are all showing some things they will do for that. We can do mucus flutter devices. I think their green pickle is what some people have used in the adult world, and that device causes a vibration and helps loosen the secretions. They have a vest that they'll put on these babies and toddlers that will give the postural drainage and do that thumping on the back. This is really good for any respiratory issue. Bronchial dilators to ease the expectoration of the secretions that are thick and viscous in their lungs. We will also give them Pulmozyme. This is an aerosol medication that decreases the viscosity of that mucus and helps improve their PFTs. Exercise. If they have an infection, we get them on antibiotics immediately, IV-wise. Some of these kids will be at home with a central line, and the parents will give the meds that way. Once again, be very careful with their oxygenation. Only give it if they absolutely need it. So this is one of those things that the doctors don't typically let the nurses adjust the oxygen as needed. They usually give you a very specific oxygen prescription. Up to 2 liters, nothing else. Not wean as needed or adjust as needed. Diet. So nutrition is huge in these kids. Their pancreas isn't able to secrete the pancreatic enzyme needed for good digestion. So they're going to take pancreolipase and pancrease. This is in a capsule with little beads in it. These need to be given with every meal and every snack. With meals, they take more capsules. And it all depends on how many capsules they take on how their stools are. So if they're having regular stools, then their medications are right. If they're not having enough stools, then they're going to increase the amount of capsules they take. They're going to have a high protein, high calorie diet. We may supplement with 2 feedings. In infants, the capsules we will break apart. Even 2-day-olds will get a little applesauce and I'll put it on the roof of their mouth and then they'll drink their bottle. Typically with this medication, we don't open up the capsules, but for infants, since they can't swallow a capsule, we will alter that. There is a powder form, but you put the powder on their food and then it starts to digest it before the child even eats it. So we don't like to use that very often. All right, almost done. Cystic fibrosis, our assessment, we're going to do good respiratory assessments. We're going to do diet and nutritional assessments. We're going to listen for their lungs, get those diet histories, get weight histories, looking for muscle wasting, fatigue, pallor. Food is a huge therapy, so finding out, are they eating good, healthy foods? How often are they using their CPT devices, and are they taking their medications like they are supposed to? What their stools are like. What other assessments? We're going to look for a clubbing of their fingers. We're going to look at their color of their skin. We're going to do lots of family counseling, hand washing to help prevent infections, making sure they're getting their immunizations. These kids can live a long time with good medical management and nutritional management. They do get put on lung transplant lists, but that just prolongs their life. They can live, we do have some stories of people living into their 50s and 60s and getting their first lung transplants at those ages. All right, that's it for the respiratory symptoms and issues.